We're switching things up today. The introduction is coming from
this guy, which that was kind of an intro already, but so back with next episode of Eye Break, Dr. Matt LePage,
Dr. Luke Small,
and we are here to talk to you about diabetic retinopathy today. So first, though, we have a super fan question from who?
All the way from Sweden. Sven Svensson has asked us a question.
Wondering, can every diabetic get diabetic retinopathy? The answer, we're going to get into that a bit. Yes, theoretically. So diabetic retinopathy, what is it? It's basically the eye is becoming damaged from elevated sugar levels, causing bleeding inside the eye, ischemia, the blood vessels become leaky.
Define ischemia.
Ischemia, pardon me, lack of oxygen to a certain area, a certain tissue. So inside the eye, if the blood vessels are becoming less efficient because they're leaking more, they're not delivering the blood that they're supposed to be delivering to the retina.
And we've got some pretty small little vessels in the back of our eyes, in the retina. They're tiny and they therefore can be damaged. And if your general sugar is not well controlled, as many of our type 2, even our type 1 diabetics have, then this can lead to what we call retinopathy. And so again, when the question, Sven's question was, could this happen to everybody? Well, if they're out of control, generally it will. It's those patients that either have the really high sugars or the big ups and downs.
Duration of disease too. If you've had it for 20 or 30 years, higher probability of something going wrong and then if you're a new diagnosis, right?
Absolutely. One of the first questions that we're going to ask you is, what is your hemoglobin A1C? And you go, pardon me? But that's our 3-month average. And anybody who's a diabetic that's seeing their general practitioner should ask that number, because that's really going to tell you your risk for diabetic retinopathy. Our magic number?
7.
7. I like 7. If you're under 7, we're ideally trying to get you under 7. And for those patients that are, I have those patients that their 3-month average are 10s, 11s, they're scary.
Makes you nervous.
But if you can even get down to 9, let's get some baby steps to go down. And how do we control that? Well, all those things that we've talked about in previous episodes in regards to no smoking, staying active, good nutrition, all the things that your nutritionist would tell you, your general practitioner would tell you, any of the specialty people that you're seeing, endocrinologist who's your diabetic doctor, is going to tell you it's all based on your lifestyle.
100%. Yep. Now, the one thing with diabetic retinopathy, there are stages. So you've got your mild through up to severe non-proliferative diabetic retinopathy. So it starts out with your small little bleeding, getting into the bigger bleeds, larger areas of ischemia, more leaky vessels inside the eye. Eventually, once it reaches a certain stage, it turns into proliferative diabetic retinopathy, which is basically new blood vessels are being sent into these areas that aren't receiving enough oxygen and nutrients. New vessels trying to deliver more blood to these areas, but
which you think would be helpful?
Theoretically, you may recall from our previous wet AMD episode that this isn't always beneficial, and these new vessels can sometimes become quite leaky and bleed much worse inside the eye.
Often we'll see it initially sort of in the peripheral parts. So if there's not really corners in the eye, but if we can go in and around to the edges, we have the Optimap ultra-wide scanning device that will take a picture and be able to detect these small little changes in the peripheral retina. But that's usually just the sort of tip of the iceberg. And if things get worse and worse based on your sugar control, then what can actually go wrong? Why should our diabetics care about this?
Great question. So initially, visually, they perhaps may not notice anything, depending on where the bleeding is and the severity of it. It may be completely unaware of it. We would see it on our retinal exams. Early stages, they, again, probably notice nothing. Perhaps, depending on severity, maybe some floaters, but if it affects the macula, it can cause a significant reduction in vision. If you start to develop scarring, then it can ultimately lead to blindness in that eye.
Absolutely, and we've both definitely had those patients that unfortunately often will look at this disease as not their problem. They look to other people to take care of that problem, but it's absolutely them taking responsibility of it. If they're coming in with a big jug of coffee with 10 sugars in it and a couple donuts, chances are good that they're not taking an active role in their nutrition and in their disease.
So, eyes aside, yes, of course it's important to monitor our eyes and our vision, but relative to the whole body, what does this have to, why should we be paying attention to this?
Absolutely. So it's analogy time. We love our analogies here. And mine, not that it's an analogy exactly, but your eyes are the canary in the coal mine. So if something's going on inside your eyes that we can detect, absolutely there's probably something going on systemically in the rest of your body. So here at Armstrong and Small Eye Care Center, all 4 of our doctors, we will send a letter back to your GP, your general practitioner, your family physician, to let them know exactly what we've seen. Whether it's good or bad, we like to communicate with these other doctors, your medical team.
Absolutely.
Yep. So one of the bigger things from an optometric standpoint is glasses. So we get people that will come in, my bad diabetics, a bag of glasses. And why do they have a bag of glasses?
Because as their sugar fluctuates, pair A may be good in the morning, but pair B might be good around noon, and then pair C in the evening. So as your sugar fluctuates, maybe not that quick through the day, maybe perhaps, but
yeah,
more commonly over a couple days period. But there's a sugar derivative that gets absorbed into the lens of your eye, the crystalline lens. When that gets absorbed in the lens, it also absorbs water, which causes the lens to swell and can change your prescription quite a bit. So yeah, as your sugar levels fluctuate, your prescription changes.
Which leads me right into the next phase, is that if we're talking about someone who's had a few more birthdays and their likelihood of cataracts, right? So our wheelhouse of cataracts for people probably ranges from 55 upwards. But if you get someone who's out of control with their diabetic sugar control, their cataracts onset will be much, much quicker. So that's something that we're trying to talk to people, talk to our
100%.
patients about.
Yep, 100%.
So I think that nails it for diabetic retinopathy. Thanks you very much for tuning in. And once again, be wise.
Take care of your eyes.